Trigeminal nerve, the fifth trigeminal nerve, the fifth cranial nerve or trigeminal nerve, motor and sensory division. 3 branches, V1 sensory, coming out through the supraorbital notch, V2 coming through foramen rotundum, with the ganglion, the pterygopalatine fossa, infra-orbital nerve, as Gavin's discussed, V3 coming out of foramen ovale with motor and sensory branches, going into the masticator space, which we already discussed in the cancer lecture. From the point of view of technologists and radiologists, when you're talking about facial pain, your coverage needs to be quite wide. You need to go from the front of the nose back to the back of the brainstem in your coronals. The coronal is the most important imaging plane. Because look how V1, V2 and V3. V3 goes to the chin and V1 goes back to the vertex. And you've got to cover the ear as well, the external ear. Okay, so axial coverage, you can reduce it a bit, but get below the chin on the axials, just below the chin. You've got to have, obviously you're going to have a brain sequence, but your coronals have to go back to the back of the brainstem. So potential causes, the central, the brainstem, the basal cisterns, they're the things we get really excited about. Like, is that nerve impinging upon is that artery impinging upon the trigeminal nerve? The skull base, Meckel's cave, cavernous sinus skull base, Gav emphasised in his petrous apex talk, and the peripheral, the 3 divisions. And then the things that we don't do very well, like the end organ. Well, we've seen loads of end organs, teeth I'm talking about, in the dental lecture today, and the regional pathology, which is again something that tends to be a bit of a blind spot for radiologists when they're looking at facial pain cases. Referred pain, we all know what referred pain is in terms of its context, like the patient who has a heart attack who experiences pain in the same dermatome down the left arm or in the side of the jaw. But it's a bit more complex in the head and neck because of the distribution of the nerves, their embryological relationship. And there was a good article by Chen in Neuroradiology in 2009 showing the complex innervation of the maxillofacial region and the upper pharynx by cranial nerves 5, 7, 9 and 10. And you can see the emphasis on 9 and 10 innervating a lot of the pharynx, and cranial nerves 5 and 7 innervating the oral cavity and the nasal cavity and nasopharynx. And the important thing is that pathology in any of these distributions can lead to pain, facial pain, but particularly otalgia or ear pain, which is not of ear origin. So the other thing that we mustn't forget are the cervical plexus, cranial nerves 2 and 3. So why does this occur? Well, you can see from the embryological basis, cranial nerves 5, 7, 9 and 10 are clumped together. They have the branchial arches originating from 5 and 7. We have the upper cervical plexus next door. They intermix both at the peripheral level, at the brainstem level, and even at the cortical level. So when you look at the ear, the innervation, the external ear and the middle ear is incredibly complex, with contributions from cranial nerves 5, 7, 9, 10, and the cervical plexus, lesser occipital and greater auricular nerves C2 and C3. Probably important to remember that the glossopharyngeal nerve or cranial nerve 9 innervates the middle ear. So if you have a tongue-based tumour, it may present as earache. So the central causes, really not that common. MS, 3% of trigeminal neuralgia is related to MS, intra-axial tumours, 0.8% of trigeminal neuralgia. Vascular loops are the big etiological factor if you consider only trigeminal neuralgia. And then other tumours and masses are uncommon, like our petrous apex lesions, for example, that we've been looking at. If you take the widest part of the pons, the pontine isthmus, the main fifth nerve nuclei lie posteriorly, with the motor nucleus being medial to the sensory nucleus, and they're exiting at that cisternal segment of the trigeminal nerve. So when we look in schematics, in the sagittal plane, we have a motor nucleus, We have a mesencephalic or proprioceptive reflex going towards the midbrain. We have a main sensory nucleus, and then importantly, we have a spinal sensory nucleus which may go down to C3 or C4. Hence, we have to cover that brainstem on one plane down to that level. So, trigeminal neuralgia, they're normally young patients, as you know. Typical demyelination plaques, a budding and peel surface with correlation with Dawson's fingers on the sagittal image. In contradistinction to this, patchy white matter hyperintensity situated more centrally may involve the trigeminal nerve nuclei. Seen in older patients, this is small vessel ischemic gliosis, but be very careful about attributing this as a cause of facial pain. I generally wouldn't. Now, in terms of the dividing the nerve up, and Gavin showed some images of the cisternal 5 already, we have a motor nucleus medial, M for medial, sensory, lateral, the root entry zone, the cisternal segment, and the porous trigeminus before the nerve goes into Meckel's cave. And it's this blue segment of the nerve which may be impinged upon or compressed by vessels or mass lesions. So, basal cisterns, normal nerve, right-sided facial pain. Okay, root entry zone, porous trigeminus, Meckel's cave. So extra-axial masses may compress that segment of the nerve. We may have vessels. We may have arteriovenous malformations or dural AV fistulas or dilated vessels, as well as normal caliber vessels. The superior cerebellar artery is the culprit in those cases of vascular impingement causing trigeminal neuralgia. Basal cistern masses. The acoustic neuroma may be associated with an arachnoid cyst, leading to more mass effect, and 17% of acoustic neuroma cases have facial pain. I don't think it's that common, actually, judging on the number of large acoustics we say, not many of them have facial pain, even when their trigeminal nerve is being nutcrackered by a large mass, as in this case. This patient did have facial pain. It was in V1 on the right side, and you can see the associated arachnoid cyst. And the enhancement of the tumour, normal trigeminal nerve, elevation and compression of the right trigeminal nerve. Maybe a problem afterwards. I've seen patients, we notice this, and patients actually get facial pain after extensive surgery. And here we see on the original drive sequence the superextension of the tumour compressing the cisternal portion of 5. Okay. Following surgery, we have a nerve which doesn't look very happy. There's cystic gliosis and encephalomalacia within it. I mean, there's a normal appearing nerve on the other side. There's nothing wrong with the surgery. It's just an expected sequela of removing that mass. Meningiomas we've talked about. Remember the obtuse angle with the bone or the meningeal surface. Okay, unlike Gavin's case, they can go into Meckel's cave via the porous trigeminus. They can go laterally into the internal auditory canal, but normally they don't expand the internal auditory canal. And the obtuse angle and homogeneous enhancement are important differentiating factors from a schwannoma. So, vascular impingement, the pathogenesis. Normal situation on your left, no vascular compression. On the right, a vessel contacts the nerve. Now, the theory is the vascular impingement causes the myelin to be worn away, causing axonal fibre disorganisation, which leads to hyperactivity of that main sensory nucleus, which give bouts of electric shock-like pain, like a short circuit going down the nerve. Now this video clip's courtesy of Dr. Rowan van den Driesen, one of the partners at PRC. And this in red is your artery, okay, which is pulsing. The nerve, its myelin sheath is in that beautiful violet colour, I suppose. It's being worn away. There's our nerve rootlets, which are becoming disorganised, thickened and nodular. And this is what happens when you get significant vascular impingement and why patients get trigeminal neuralgia. So when is it significant? Still the best guidelines are from 2005 from Alexandre Bourges. Artery, displacement not abutment, crosses at 90 degrees. So if it's parallel to it, it's generally not significant, or it's slightly oblique. And it's got to be within 6 millimeters of the root entry zone. These are guidelines. It's not true in every case. Trigeminal neuralgia, or tic douloureux, it's only 10% of facial pain, okay? But this is what we spend most of our time looking at. It's low incidence, common in females, and 50% have trigger zones. They touch the face and they get a reflex pain. Divided into two types. The classic is type 1, the commoner type, with the intermittent, sudden, sharp stabbing, electric shock pain. Then there's a type 2, which is less than 50%, constant aching and burning, and does merge with other types of facial pain. It's felt most commonly to be due to a vessel. Here we see mild impingement. I tend to invert my drives or my cysts or my fiestas because to me it helps look at impingement more clearly than when it's the opposite way around. So that's just video invert. We see the vessels, the superior cerebellar artery. It's impinging on the nerve. It's only mild impingement. This patient was operated on despite the fact it's way away from the root entry zone and did have relief of their symptoms. So there's a supromedial indentation on all the sequences, the 90-degree crossing of the vessel, but it's 2 millimeters proximal to the porous trigeminus. But you can see the nerve is bowed and also a little atrophic as well. You may have combined venous and arterial impingement. Okay, so there's a vein, it's an ascending petrosal vein. There's the artery going right through the nerve. Okay, there's the vein, there's the artery further superiorly, and the nerve is also atrophic on that side. So the traditional view is you only do MR to exclude other causes of pain. In fact, the evidence is, and it's improving as our imaging improves, that it's much more than that, particularly if you know what you're looking at and you have good quality imaging. So in 2005, at 1.5, 72% of cases were predicted preoperatively. 2011, this is still the best results I've ever seen. This was from Brazil, where they have a huge clinic in São Paulo that treats these cases. They had a very, very high sensitivity and specificity, and approximately 1/3 of their cases were due to veins. Certainly in WA, not many neurosurgeons would. Well, I only know one who would operate on vein as a potential impingement cause of trigeminal neuralgia. So if you believe that, 3T MR is highly accurate in the diagnosis of neurovascular compression. And what they concluded was you had to determine the vessel type, you had to say where it impinged upon the nerve, and the direction. So was it at 90 degrees, was it oblique, or was it parallel? And remember, 90 degrees is the most important one. And was it severely compressed? Did it just touch it? Did it push it away, or did it push it away a long way? And, and I would add atrophy with that as well as being a good sign of long-standing compression. Before you get an atrophic nerve, you may be able to pick up that the myelin's abnormal using a technique called diffusion tensor imaging. I have no experience in it. It was written by Lutz et al. In Radiology 2011, and basically uses a combination of a 3D technique with diffusion tensor imaging. You can fuse the images and you can look for a thing called fractional anisotropy, and it's lower on the affected side in trigeminal neuralgia. And basically it's a diffusion weighted technique. So you get decreased directionality of diffusion. It tends to go all over the place rather than going one direction when you lose myelin when you had that sheath, when you had those disordered nerve roots. So you get increased ADC. So exclude other causes. So this is the role of imaging. If you accept that neurovascular compression causes 90% of classic trigeminal neuralgia, which is 10% only of facial pain. So exclude other causes. Try and define your neurovascular compression or impingement if it's present with the factors that we've already discussed. Quantify your severity of compression as mild, moderate, or severe, or 1, 2, 3, because it's directly proportional to the surgical outcome. The greater the degree of impingement, the more likely you are to get relief of pain from having surgery. And then diffusion tensor imaging may be relevant because it may tell us which patients may respond to surgery. Because remember that you took 40% of the people in the room, 40% would have, 40% of people in this room would have a vessel contacting their trigeminal nerve. So a little bit of anatomy, okay, for the skull base causes. So we have V1 in the cavernous sinus, we have V2 in the cavernous sinus, we have V3 in Meckel's cave exiting through the foramen ovale, and on 3T imaging, this is off our own magnet, V1, V2 and V3 on post-GAD high resolution Thrive sequence on the Phillips magnet. And Meckel's cave. And note the Gasserian ganglion or trigeminal ganglion is a U-shaped structure slightly on its side. So you see the normal Gasserian ganglion. Facial nerve schwannomas. Okay, heterogeneous enhancement. Remember the Antoni A and the Antoni B, no dural tail, smooth bone expansion. Going to the foramen ovale, meningioma, more infiltrative pattern with obtuse angles, dural tails, may mimic perineural tumour spread and go through the foramen ovale along the V3 nerve. It's going into the middle cranial fossa as well. The normal foramen ovale on the contralateral side. The aneurysm, Gavin said they may look bizarre on MRI. The zebra look on the right. Okay, this is a 37-year-old GP who presented with facial pain, was actually diagnosed as having a meningioma on CT. And it wasn't. You can see the various sequences. It's change really that gives you the clue that you've got a giant aneurysm. And the MRA, of course, may not be significant apart from the mass effect if that aneurysm is thrombosed. Okay, and the homogeneous enhancement, the compression of Meckel's cave, and you can see that the Meckel's cave is contracted and thick-walled. That's the compression effect of the aneurysm. We have seen cases of neuritis which have responded to steroids, and you know, it's obviously a hypothesis rather than a diagnosis. But if you compare the two sides, right side of facial pain, Meckel's cave is smaller, the nerve roots are clumped, and when you give gadolinium, you can actually see neural enhancement within the Meckel's cave. Now, I can't tell you that isn't due to perineural tumour, but there was no known primary, and the patient's pain got better on steroids. The enhancement did go away, but not the clumping. So there are some changes which are going to be irreversible. That's our hypothesis, and we've seen that on several patients. So again, facial pain, peripheral causes now. We've got out of the skull base. We're on the downward road. So V1 sensory, V2 sensory, and V3 sensory and motor. So remember with V1, supraorbital notch, the forehead back to the vertex, going back through the supraorbital fissure, and then back into the supraaspected cavernous sinus. So this is a 73-year-old man with pain and altered sensation in the V1 distribution, history of exogenous skin cancers. There's his perineural tumour spread going along his V1 nerve in the supraaspect of his orbit. There's another primary tumour. Back to the supraorbital fissure. V2, okay, the infra-orbital foramen, back along the orbital floor. Links up the pterygopalatine ganglion for parasympathetic and secretomotor supply. Goes back along foramen rotundum to the cavernous sinus. This is a young man who presented with altered sensation in the V2 distribution. An altered sensation has got a totally different meaning to pain. If you've got altered sensation, you haven't got trigeminal neuralgia, okay? You've got something more sinister going on. So an enhancing subcutaneous mass involving the left infra-orbital nerve. And this was desmoplastic melanoma. Okay, there's the involvement and asymmetric thickening of the left infra-orbital nerve and going back to V2 in the foramen rotundum. Similar person with melanoma. 70-year-old male, progressive numbness and pain in the left V2 distribution. So I'm not going to do an MRA on these patients. What's that going to tell me? You know, if he's 70, you know, it's just not relevant. So we have to do high resolution imaging, we have to give GAD, and we have to use FATSAT because we've got the potential to be dealing with a malignant cause. So pain on V2, going back to Meckel's cave, there's the swollen and asymmetrically enhancing left V2 nerve. There's a sagittal recon of the 3D volume set going back from the pterygopalatine fossa back to the brainstem. And there's focal gliosis in the brainstem with perineural tumour spread back to the brainstem, so therefore it's inoperable. Denervation atrophy of the muscles of mastication, because V3 is also involved at somewhere along the line by that tumour, and that's the motor supply to those muscles. So V3 perineural tumour spread. All these peripheral neuropathies, your T1 is the most important image. You have to give GAD, you have to give FATSAT, but you're looking for asymmetry on T1. Okay, so there's the normal V3 nerve going from the infra-orbital foramen and going from the infra-alveolar foramen and the mandible to Meckel's cave. There is the normal nerve on the T1 coronal. There's an asymmetrically thickened right nerve. Give GAD, we apply FATSAT, we can see our tumour going into the middle cranial fossa and the cavernous sinus, and we can see that there's denervation atrophy with patchy enhancement of the muscles of mastication. This is perineural tumour. Okay, so remember there are several branches of the V3 nerve which come off before it goes into the foramen, of which the most prominent is the lingual and the auriculotemporal, and we'll talk about the auriculotemporals later on actually in this talk. I was hoping it was going to be later, but it's not. So you can see the lingual nerve in normal patients at the back of the mylohyoid, and you can see it as a little curvilinear line, and it's going back towards the infra-alveolar foramen where it originates before the V3 nerve goes into the mandible. So this is a V3 schwannoma showing very nicely the clue. Now, you could just say this was a deep lobe parotid tumour, and you wouldn't, you know, you'd be right 99% of the time if you looked at just that soft tissue window image and you didn't pay regard to looking at bone windows. But there's a large mass, there's expanding the infra-alveolar foramen. You look on MR and CT combined, dumbbell-shaped or multilobular tumour with the typical T2 pattern of a large schwannoma, and that's what it was, a V3 schwannoma. And note the normal nerve surrounded by fat in the masticator space on the right side. Lymphoma, 53-year-old with right V3 pain and altered sensation. Okay, what do we note? Well, I emphasise it with the cancer talk about using your bone window images. Get your text to reprocess every head and neck case on bone and soft tissue windows and review your bone data. Okay, the soft tissue shows a mass, all right, anterior to the masseter, and there's abnormal soft tissue in the bone on the soft tissue windows. And where is that? Well, it's in the expanded right infra-alveolar canal. Okay, so we have a tumour which is extraosseous, but it's also involving the right infra-alveolar canal. And this was non-Hodgkin's. So on MR, T1 marrow is bright, and fat is bright. So they're your helps. The T1 is your friend. Okay, there's the tumour going into the bone. We give GAD, tumour and the marrow enhance. And we look at our coronal images. Okay, so there's our normal V3 nerve. There's our infiltrated fat nerve. And there's the nerve growing from medial to the mandible up into the foramina ovale. And it's involving the mental nerve as well. So the patient had the correct signs. They had numbness in V3, they had a numb lip, and they had a numb tongue on that side as well. So in terms of large nerve perineural tumour spread, it's an extremely difficult diagnosis for everybody. It's not uncommon, particularly in Australia where you have a high incidence of skin cancer. There's often a clinical suspicion, but that may be masked by the fact there's a time lag. And not everybody can remember, an old digger can't always remember when he had a skin cancer cut off because he's had so many cut off. There may be no history of a primary. The imaging is very dependent on MRI, the technique and the experience. And histopathology exactly the same. And clinical details often help as well. And you know, most of the time you do get good clinical details when you're doing these cases. And Gavin and I, Rudolph, we work with a specific perinatal tumour protocol. And as I said, if we get facial pain, we have a trigeminal neuralgia protocol. If we get a history that suggests a change in sensation, then we go on to our perinatal tumour protocol. It's devastating for the patient. Failure to diagnose it is catastrophic. There's a great article in JMeiro, I think last month, by the group from Queensland, Mitesh Gandhi and Ben Paniza has been the surgeon, that is really a world-class article on evaluation of perinatal tumour, and I commend it to anybody to read. So now the meat really in the sandwich, or the avocado if you're vegetarian, or the soy or whatever. But these are the bits I want you to think about. You know, you've had this, we structured these talks like this, so I would get you with the teeth, Gavin would talk about the sinus, and we've emphasised the interrelationship between the dentition and the surrounding bones. But what we need to emphasise now is the neurovascular relationships. Yes, you can feel a toothache related to a tooth, but you may feel it in the maxilla when you have a mandibular dental abscess. You may feel it in the ear, you may feel it here, you may feel it in the TMJ. It's not a strict anatomical basis. You can say that is the cause of that patient's pain. So dentition, alveolar bone, sinuses, all these other structures, TMJ, T-bone, pharynx, upper neck. So referred pain, as I've said, cranial nerves 5, 7, 9 and 10, all sites that they innervate, they're all interrelated, and C2 and C3 with the cervical plexus. So this is a 37-year-old male with right V2 pain, normal sensation. Luckily he had a CT first, and he's got a big periapical abscess, as you can see. And he's got reactive mucosal thickening. He had the tooth removed, and his pain went away. Okay, there's the oblique sag. Oblique sagittal is very nice in the upper and lower jaws for giving you an overview of what's going on, like a half panorama from an OPG, really. This is 40-year-old male with left sphenoid sinusitis. He has facial pain. Now, why does he have that? Well, his sphenoid sinusitis on his CT is affecting his foramen rotundum. It's got sclerotic margins, and when you do MRI, there's asymmetric enhancement of the main trunk of V2. So that is a facial pain due to V2 neuritis related to sphenoid sinusitis. There's a normal V2 nerve on the other side. That little nerve, just want to emphasise, is the Vidian canal, which is a link between 5 and 7, and also important in facial pain and perinatal tumour. Now this patient, 31-year-old female, she's had V3 pain for 4 months. She's been put on Tegretol. She's still got pain. She's had 2 normal MRIs for trigeminal neuralgia, which did not give the coverage that we talked about at the beginning. She eventually has an OPG. We see this periapical pathology. We ring up the doctor, we get a dent scan. And you can see there's a periapical abscess with an inflammatory phlegmon. She had the tooth treated and her pain went, and she didn't have trigeminal neuralgia. And that is not an uncommon scenario. And the principal problem is that you have very experienced medical physicians, like neurologists or pain experts, who are experts in the diagnosis of the neurological causes of facial pain. Then you have the dental specialists who are very good at diagnosing the peripheral causes, but their knowledge of central causes is not so good. And do the two meet? No, unfortunately they don't. It's the radiologist who often has to bridge those disciplines. So here we have a patient who's known to have prostate cancer. I think his plain films were normal from memory. He's got a lingual nerve and infra-alveolar nerve on the right side, which is normal. Okay, he's got normal marrow in his right angle. Again, the T1, this is all a T1 diagnosis, nothing fancy. He's got infiltrated marrow in the left mandible, and that's the cause of his V3 pain. So he's got bony metastasis from prostate cancer. So there's myriad causes of referred otalgia. And I thought the diagram was probably better than listing them as we're getting to the end of the talk. But think wide, okay? If you want to cover referred otalgia, I think CT gives you better coverage than MR if there's a specific reason. But we have to think of all the innovation of all these regions as being a potential cause for pain referred to the ear. So, 61-year-old male with right referred otalgia. Okay, everybody saw the tongue-based carcinoma there with the activity on the PET CT. Another common nerve that we mentioned, one of the branches of V3 that comes off just below the level of the skull base is the auriculotemporal nerve. Now that's quite a complex nerve. It goes around the back of the condylar neck, innervates the TMJ, and it innervates the skin of the temporal fossa and the skin at the front of the ear. Now, that's not just academic interest, because we're seeing more and more of these nerves involved by perineural tumour with 3T imaging. And there it is going to supply the skin in front of the ear and the anterior part of the EAC. Now that, as well as communicating with the 7th cranial nerve and having a cutaneous and ear supply, carries secretomotor fibres from the 9th cranial nerve to the parotid gland, passes posteromedial to the condylar neck, and as I said, it joins the cranial nerve 7 within the parotids. So it then provides a link for perineural tumour from 5 to 7 to 9 or 9 to 5 to 7 and go either way. So when you look at the nerve, there's where V3 should be in the medial aspect of the masticator space, okay? And that's where the auriculotemporal nerve is going to join it. That's the path of the auriculotemporal nerve. There's cranial nerve 7. So tumour, slightly dirty fat, a bit posterior to the mandible and the parotid can be your only indication that you're dealing with auriculotemporal perineural tumour. Cone beam, or con beam, as I prefer to call it in some ways, is a dangerous examination to do in somebody with facial pain, particularly when they're old. So you have a normal cone beam. On CT, eventually the patient comes, they present with TMJ pain. They had a normal cone beam. They eventually had a CT which shows an infiltrative mass in the superficial lobe. And then on MR on the T1, we can see the normal facial nerve at the skull base, but there's involvement in the auriculotemporal nerve. And that patient subsequently died within 9 months of metastatic disease. So in terms of imaging protocols, if you have a central cause, MR is definitely the best cause, but you've got to cover the full course of the 5th cranial nerve. These are suspected causes, okay? You've got to cover the skull base, and CT has a definite role if you see anything abnormal on MR. And peripheral causes, we have to, if we want to look at the nerves, obviously MR, but if we want to look at the end organ, the sinuses, dentition, CT is still the king. And for me, and I think for Gavin as well, we would say you're starting off, you want to do a good screen, and you don't think the patient's got trigeminal neuralgia based on the neurological examination, particularly if it's coming from a GP, I would do post-contrast CT every time. And I would start just below the submandibular salivary glands, give a reasonable bolus of contrast, I'd look at the bone windows, and I'd cover the resultant area. So in conclusions, a specific clinical diagnosis may be possible, especially with peripheral causes of pain, but isn't often applied. Trigeminal neuralgia is uncommon. There's a definite role of MR. Many cases cannot be compartmentalized, and beware of warning signs or symptoms, i.e. numbness, tingling, fornication is the other word, which always sounds quite rude to me, but I think that means that feeling of ants crawling on your face. It's said to be pathognomonic of perineural tumour. And comprehensive evaluation is required. You've got to cover from C3 up to the vertex, either with CT or with MR, and if you use an MR, get an OP, good quality OPG, and look at it carefully as well.